think will help engage providers in opioid projects in a way that doesn't question their clinical competence to prescribe opioids nor their good intent in helping us and partnering regionally to combat the opioid crisis. So that's really what we want to get to here. And I think we have a really great sort of lineup for this. And if we go to the next slide, let me just say that we decided to do this as a webinar just so that it would be easy for us to show you a couple data templates that we've been working on. But the webinar does come with some restrictions. So you are all in listen-only mode. And this slide shows you a little bit about the audio options. And then if you have questions, please use the questions section in the webinar panel to submit any questions or concerns you may have. Our panelists will answer questions at the end of the presentation. And I really encourage you, we really wanted this to be a dialogue, so we were somewhat in conflict about whether to make it a webinar or just a dial-in phone conversation. And as I said, we chose the webinar function, but we're hoping to have this be as interactive as possible. So I really encourage you, there's no bad questions. You can ask us anything you want. This is really our opportunity to work through, I think, some really pretty meaty issues that might have implications for other data products we also are producing down the road a bit. So it's really going to be worth our time to enter into a dialogue around this. And we are really fortunate today to have the Healthcare Authority's Associate Medical Director, Dr. Emily Transu, pronounce that right? Who's going to start the dialogue by getting things to clinical perspective.
Thank you so much. So as I was sort of thinking about what to talk about here today, it's funny to be talking about data and at the same time a certain amount of it is sort of psychology. So there will be a little bit of both of those things in what I'm going to talk about, and that's going to be sort of partly to how you guys are using and thinking about data, partly to thinking about how clinicians think about data and sort of what we hear when people talk to us about data, because I think this is an area where there's so much potential, but where there are also some things to kind of look out for and really think about from a provider engagement perspective. And I'll kind of use the opioid data that went out earlier as a use case to sort of talk about that a little bit, and then also kind of think about some of the data ideas that I have from a clinical viewpoint. So as I think about the uses of data from a clinician's perspective, data can be used to understand the population, and that can be sort of overall population health and sort of the specific patient population and groupings for specific diseases or conditions. And then kind of your provider population, where and with whom is care happening for these patients and these conditions. So it can be used to understand the population, both the providers and patients, and then it can also be used to judge quality. And that can be quality of the overall care that's being delivered on a population basis, and the quality of care being delivered for given conditions, the quality of individual provider performance, and then, of course, at an extreme, it can be used for discipline around malpractice, around fraud, waste, and abuse. So all of those things sort of get more and more narrowly focused on particular providers as you kind of go down that list. And as you're doing that, risks of misinterpretation and miscommunication really grow. One thing that I'll really focus on, because I think it's important to the way providers hear data, is understanding that performance on measures is very, very heavily dependent on the particular subpopulation of patients that someone is taking care of. And there are some ways that that's looked at, sort of the risk adjustment generally is the word for it, but that can encompass a number of things. So it can be heavily dependent, of course, on the disease burden in that group of patients that someone's taking care of, on the patient characteristics in terms of their ability to adhere to recommendations and participate in different kinds of care, And then, of course, the social complexity as well. So if you were looking, for example, at a provider's data and saying, you know, whether that's a doctor or a hospital, saying, this looks really bad, which I think we've all looked at some data and had that thought, that might be because they're giving bad care, or it might be because they're giving good care in a really challenging population. And this is not just theoretical, this is something that happens in real terms all the time and with major repercussions. So for example, safety net hospitals tend to look horrible on a lot of quality metrics. And that's not because they're doing a bad job, it's because they're working in really tough populations. There's been a recent struggle around some of the metrics that are used to incentivize hospitals. And what do you do when Harborview and Overlake are not seeing the same kinds of people and they have different rates of readmission for very different reasons, not to pick on Overlake. But recently there was a doc who was investigated for having really high narcotic use and levels. And the investigation showed that she had inherited a big group of patients from another provider who had retired. So inherited this big group of people who were on high doses and on multiple medications. Nobody else was willing to take these folks, and this provider took them on and was working very carefully and systematically on getting those doses down, but nonetheless got sort of caught up in a net of, hey, your numbers look really high. So these are real things, and I think this is particularly an issue around narcotics specifically, since as many of you know, this is an area where providers lose their licenses and where HCA has shut down a series of clinics. A number of people have been disciplined around this. So there's anxiety out there, a little bit around quality in general, but very, very, very heavily around narcotics, which doesn't mean that all of these things shouldn't be looked at, but I think ACHs need to really think about not pushing the buttons of making somebody feel like, oh, you're saying I'm not doing a good job, when that really may or may not be true. We really want to support you in building trust with your providers. And kind of thinking about this from a, we appreciate you're taking care of this population, which is not a given that people are going to do. And let's kind of look at how we can work together for mutual benefit for our patients and each other. I think it's also important to have a little bit of a historical context on the slightly checkered past of quality measures in the provider community. First, that they haven't always been measured or risk adjusted well. Second, I sort of hate to say this, but I think it's important for people to know it, that the promise of paying for value and not for volume is something providers have been hearing for 10 or 15 years, and they're all still having to do more volume. So there's a little bit of a grain of salt that you may encounter as you're dealing with providers around data, that they may sort of say, yeah, you're saying you're going to make this all better and reward me when I do good work, but I'll believe it when I see it. There's also that certain metrics, we all try hard to use clear metrics, but some of them are ambiguous. A metric that recently was discussed at one of the BRIE collaborative meetings was the percentage of one's narcotic patients who are on chronic narcotics. And the sort of assumption was, well, fewer people should be on chronic narcotics. But that's a ratio measure. That's a chronic narcotics over all narcotics. So if you stop prescribing a lot of acute narcotics for, people spraining their ankles and say you can really get by with ibuprofen and Tylenol instead, your percentage of chronic narcotics goes up because you're not pouring all those acute narcotics in. So sometimes what looks on face value like one thing can really be another thing. So I would say that globally for the provider community, I think people are kind of generally on board with all this quality stuff, but they have some really significant and often appropriate reservations about how data is used. And the bottom line, to kind of go back to what Kirsta said at the beginning, you really want to be sensitive to not making providers feel like their care of patients is being judged in an inappropriate way. So to specifically use the data that was sent out earlier and then retracted as an example, this was it was a very small number of providers overall. And from you guys' perspective as an ACH, one of the things you want to be thinking about is, where are the numbers big enough? How do you reach enough people to really make a dent in your population? And even if you had a couple of very high volume providers in something like narcotics, that's still not going to be a big chunk of your overall narcotics. So you want to be thinking about a slice where you can really move the needle, not necessarily a small number of people with a lot of volume. And secondly, the criteria that we put into those, and this was all done with the best of intentions and thoughtfully, and I think it just, as we got more people's heads on it, there was kind of this, oh, this is like what we meant to do, so we all take responsibility for that. But it looks like a disciplinary slice. It looks like the kind of slice of, oh, you're a bad doc, you're doing the wrong thing. There is a role for that. It is not you guys' role. And the Department of Health and HCA, through a number of venues, can and are investigating that kind of issue. And again, docs have lost their licenses, practices have been shut down appropriately. But you guys don't need to worry that that's a role that you're supposed to take on. And relationship-wise, really that collaborative, hey, this is a tough population that's being taken care of, what can we do with you for this, I think is the angle that you want to take. Just so that you're all aware, in terms of opioids, there are other efforts, very much so, that are in place and being put in place around the state. There's a prior authorization policy that's going into place, I think October 1st, it's moved around a little bit, in Medicaid. It's going to limit the number of pills that can be given out on the first prescription, and also requires a prior authorization process when somebody's kind of rolling over from acute use into chronic use. Also limits kind of total MED, morphine equivalent doses for all patients who aren't on something already. Quite how to deal with people who are on it already is complicated. There are a lot of feedback reports that are going back both to individual providers and to groups to work with their providers, and there's ongoing monitoring for misuse. So on the flip side, sort of how would I suggest you guys think about data? I would really think about using it to understand that the population and the community of patients that you're thinking about and of providers who are taking care of them. And use that to kind of identify slices of interest. And those can be patient population slices, they can be provider slices, certain kinds of docs are taking care of certain issues. Do you want to work with the dentist, sort of looking at, say, pediatric prescriptions, who's doing those? And if you looked at your data and realized that a strong majority of those were coming from dentists, you might want to think about how to work with the dentists around that. If you found that a lot of kind of this care was being done by orthopedists, or it was happening in ERs, or it was happening in primary care offices, again, you might want to really focus your projects around those slices. So I think using the data to identify slices of interest rather than individuals necessarily within that slice. And then, of course, age groups, disease groups, again, figuring out which patients as well as which providers are of interest for you to focus on. When there are questions about quality of care that arise, really approach that from a kind of appreciative inquiry perspective. What might be underlying this? What might be going on? Is it appropriate or not? Because sometimes it will be, even if it doesn't look that way. And what are the things that we can do as a community and with the provider community as a community to impact what that overall use looks like? Be really careful about not jumping to judgment. Really work with your provider communities to identify the challenges and the potential interventions. And then again, just be really sensitive to the possibility of seeming to judge care, even when you might not think it's going to look like that. Think about anything that could look like that to the provider community, because that's something that they have been historically sensitized to. are kind of the things I wanted to say. We can take questions later and kind of go on to some things that we've put together, and the team has put together around kind of data that might be useful for you in looking at.
Yeah, fantastic. Thanks so much, Emily. That was really great, and I think sets up a wonderful context for us to kind of move into the templates. And I hope this works for people who are attending the webinar, but maybe if you go on to the next slide. If we jump in and kind of look at some of the templates and then have a sort of our question and answer period at the end, it might help give us some, I think they're really hard to separate. Well, what's this new data that you're talking about going to look like? And I love Emily's characterization of identifying slices of interest. And so we kind of have two different approaches here. And the first is put together by our expert within the AIM team on prescribing behavior, and that's Shalini Prakash. And she tried to, well, I'm going to leave it to you, Shalini, because I know you are on the phone and can speak to this.
Hi, this is Shalini, and I'm with the AIM team. So I just wanted to kind of take what Emily set the stage up of as to usable information that really can be applied with the intended projects and project selection that the ACHs may be embarking on, and the planning purposes, whom to target. If there is, there are problem areas broadly, where do they lie? So to kind of address those kind of questions, we discussed and came up with a few template ideas that may give you more information about these broad slices of data, as opposed to identifying the individual providers and their volumes of opioid prescriptions, which was how the previous data product was, which in the end, as Emily pointed, may not really be objective because of all the underlying issues that may put a particular provider in a particular bucket to be a potential target for projects that you may select. So keeping that in mind, the slide that you see is really trying to summarize opioid prescription data by similar dimensions as before. That is, where are the users, what is their county of residence, but then summarizing the data at what type of provider is providing their care. So in the first, in this particular template, we have summarized opioid prescriptions for a given time period, say 2016, and summarize it at what kind of provider, based on their specialty, subspecialty, where they practice, and where they practice here becomes the county, perhaps, and what is their share of the opioid prescription? So we're still trying to get to that question that is on everybody's mind. Where does the problem lie or potentially lie? So we can walk through the data fields left to right. This particular data will also try to get to the opioids that really matter. So not the drugs that are used to treat opiate use disorder. So we would like to exclude the drugs that would, like buprenorphine, Suboxone, etc., that are used to treat the opioid use disorder, and also try to exclude other potentially high users, like those individuals with a history of cancer, that we'll be able to identify using our their claims history. So and not trying to legitimize, I don't want to use those words, but basically upfront, we know that they may have high use. So let's not just look at patients with a history of cancer. Let's not try to bucket treatment opioids with opioids for pain. So let's take them out and then look at the opioids that are being prescribed to people residing in a particular county of the ACH, and then look at who's prescribing them. So as you walk through left through right, this is just obviously just for demonstration purposes, and that's why we have lots of question marks. And as Kirsten mentioned, this is definitely, we want this to be interactive, and we are looking for comments from you all. Looking at starting with the residents of who gets the prescription, then we're looking at provider characteristics, like what is the specialty, what's the subspecialty, and these kinds of information we have available based on the provider registry that HCA has made available to it by the MCOs, etc. Then we have what's a specialty, for example, based provider taxonomy, and that's another way of saying specialty based on the claim itself. So we have, so in some cases, the way a provider NPI is registered with their specialty and subspecialty may not necessarily be the same that you may see in a claim, but just looking at that possible combinations, and then where do they practice? Which county? So instead of trying to get to, this may help identify if those receiving care have to travel outside their ACH within their county. So giving a little bit of context there. And then which particular MCO or fee-for-service type, who's the payer here? So, giving that kind of information, every prescriber could have multiple networks, multiple managed care networks they're part of. So you get to see that particular combination. And then getting down to the actual numbers, including the unique number of people that have been served. With all these characteristics of the provider, how many prescriptions of opiates were written, how many individuals were they written for in that specific time period, and getting down to a little bit more nuance about who those individuals are, the Medicaid beneficiaries are. So how many of these individuals who were written prescriptions by providers with these characteristics, how many had a history of opioid use disorder? How many have already cumulatively are on high dose opiates? So those with a high morphine equivalency per day. So getting down to those kinds of questions around the patient characteristics. And this can go more in depth, as Emily had mentioned, more around, okay, maybe a certain age group, a particular race or ethnicity grouping, and it can be certain chronic condition prevalence, and those particular dimensions can keep going, and we can get down to all possible, combinations that may point to areas that need attention.
Okay, great. Thanks, Shalini. And, as you look at this, I think inevitably, as we send this out, as you have all of you who have been recipients of our data products realize, there's a certain amount of suppression for numbers where we have numbers less than 10. And what we're finding with almost all of the data we're producing is that there are long tails, as we say, on the data, which means that there are a few who have high numbers, and there are many, many, many who have very low numbers. And I thought Emily brought up a great point that with a long enough tail, it doesn't necessarily make sense just to focus on those few providers who are high volume. You might want to spread your net wider. And so Karen Jensen is sitting beside me, who is our manager for data integration, and she has told me that the data sharing agreements with the ACHs are
out for signature.
And so she's looked at this. One thing that comes to my mind that might be useful, if you have someone in your shop who is handy with Excel or another kind of analytic program, is if you were to make a request for this type of a file through that data sharing agreement, we could provide it without the suppression for small numbers, and then you can basically slice and dice this any way you want. And that's what's really, I think, going to help you identify your slice of opportunity within this data. And as we look through the next two templates, and what we were really trying to do was start to do some of that slicing and dicing for you, right? And I'll apologize that the wording here is a little different because different people were putting these together, but this is basically saying, okay, so you have all that underlying data that Shalini went through. Maybe you're interested in categorizing this by the risk group of the clients who are receiving the opioid prescriptions. What are the risk categories of someone who might lead them to have opioids prescribed? And then we might be able to link that together with some information like the provider taxonomy. So if it's someone with high risk for diabetes, what kinds of providers are prescribing them with opioids? And again, to kind of help you make those connections to identify for your region, a category where it looks like there would be some opportunities for a fruitful project that might help lower opioid use among people in your region. So these were just three ideas of how you might be able to slice and dice. One was provider taxonomy, which is the person writing the script. The next one is by billing provider, which is more of, in our parlance with our data, is more of kind of the type of facility that is where the prescription is coming through. Another idea is to look at prescribing patterns for those people who might have an indication of a behavioral health condition, either mental health, substance use disorder, or co-occurring, because they are often higher risk. And again, looking at if someone with a substance use disorder or maybe a co-occurring disorder, if they are having a lot of opioid prescriptions written for them, where are those coming from? Are they coming from the emergency department? Are they coming from primary care? It would give an indication of a much different approach, perhaps, to your project. So if you go just quickly to the next one, again, this one is just going back down to provider taxonomy. And again, provider taxonomy, I'm not sure exactly how useful that will be in your long tail, because there's probably a few dermatologists who are prescribing some opioids, but the numbers, it's probably just information so that you can count that out and decide you don't want to include that in your project. Provider taxonomy is a fine enough level of detail that you would, it would probably only be those top ones that you would be interested in. But we could, again, summarize this information by provider taxonomy or billing provider type. And there's probably infinite variations upon this. So again, I think that speaks to the usefulness of getting you sort of the underlying data file so that each individual region can do the different types of analysis they need to identify their population. But if there are some approaches to this that would be sort of useful across ACHs, we could certainly produce this type of information. And I did see one of the questions come through, and we are going to be moving to those. And one of the questions was, I think, what we would expect, which is, well, okay, this is all well and good, but what about the actual identification of the providers who are writing the prescriptions? And we realized that if you are, once you've identified sort of the focus of your opioid project, you're going to be looking for ways to contact providers who might like to participate. And we want to make sure that that you're going to have the information you need to do that. I'll say that the way we're looking at it is this is phase one. This is the information we'd like to focus on getting you right now, and then we're certainly going to be looking at that second phase to decide to figure out how to appropriately share information with you that would allow you to identify the actual providers who you would like to engage in your projects. And you do have a lot of individual provider name and contact information and information about those providers that John Bauer has already provided, and he's here with us in the room too. So there is some of that information. We realize it may not all be easy to integrate at this point. So with that, maybe we'll start in on the other questions.
Nicole Willis is interested in learning more about the data and information available from DOH's prescription monitoring program and UW's ADAI report on opioid trends across Washington.
Shalini, have you worked, this is Karen, Shalini, have you worked with the information that's available from the prescription monitoring program?
I just want to clarify, is this really about the prescribers accessing the prescription monitoring program? So I can just, so there is a prescription monitoring program prescription data that we have some ability to work with, and there is the prescription monitoring program, and that's specific to Medicaid enrollees. There is scripts and all the scheduled drug use utilization in Washington. And the other piece is the DOA. So there are portals through which prescribers registered either through their EMR or through registering through this DOH portal are able to access some of the prescription monitoring program data, so the prescribers can make appropriate prescribing decisions. And so we have some access to which of the prescribers are registered with this portal and who they are, and we have some level of summary statistics that we are able to access from DOH. So that would be the agency from which we'll have to get that type of information. So how many, what are the, I mean, we can provide some kind of information around what those specialties are, where they practice from. So perhaps in your ACH, how many internal medicine doctors are registered, how many nurse practitioners are registered with this portal. So we are able to provide some level of information around that. If you were referring to the prescribers accessing the PMP data.
And we've gone in search of one of our opioid experts from DOH to answer the rest of that question. He hasn't quite gotten in here yet, but hopefully he'll come soon, because the second data source reference there, at least I'm not familiar with at this point in time. Okay.
The next question, what is the timing for the phase 2 that Kirsta just mentioned, given that ACHs are being asked to identify providers in the near term as part of project planning?
That's a great question. And I think if we're looking at sending out this data within the next 2 weeks, we'll have the underlying provider names beyond that. And I think as ACHs are able to articulate the slice of the data that they're really interested in. So let's just go back to Emily's example around dentist prescribing practices. Let's say an ACH has identified this as their target population of providers they would like to engage in their projects. I mean, one thing we could certainly look at is what dentists in your area are seeing Medicaid clients. And again, Emily's idea of casting the net broadly. If there was going to be some sort of targeted outreach within that, a specific type of provider, we could certainly help provide that information. So it might be more of a back and forth with a given ACH to ensure that we're providing the data and information that's specifically going to meet their target, their project needs. Oh, Dan is online. Do you want to read the previous question and see if Dan has any additional insight? Because he has the background from, or he's probably not unmuted, right? Dan Bolton.
He is now unmuted.
Okay, Dan, you're unmuted and
Okay.
yeah.
Okay. They would be interested in learning more about the data and information available from DOH's prescription monitoring program and UW's ADAI report on opioid trends across Washington.
Okay, so I can talk about PMP, not about ADAI.
Okay.
That's a record of each prescription of a controlled substance that lists the person who got it, the provider, what it was for, how many days supply, and so on, the product that they got. So DOH governs access to that. And when I've had access in the past, it was after signing an individual data sharing agreement with them. My understanding is it's still developing how we may be able to make that data in aggregate available for ACHs. As it comes out, or as it's basically available, PMP data includes everything about the person, their address, their name. So it would have to be redacted quite a bit before it could be made available. But I'm seeing that as something that we're going to explore in the context of all of the tools that we hope to offer, tools and data that we hope to offer to the ACHs. But it's not settled yet how that's going to work, I think.
All right, so we'll take the second part of that question away as take homework, and we'll get back to, I think it was Nicole who asked that question.
No other questions have come in.
All right, well, we're here for a couple more minutes. If anyone can think of a question they would like to ask us, or you're, as you always, welcome to send me a follow-up email with any specifics. Well, with that, fantastic. Thanks so much for joining us today. And again, we'll kind of move in the direction we're going with the products we've identified, unless we hear from you. So if you have modifications to these products that you'd like to see that would help you with your planning, please get those to us, and we will we'll try to incorporate your comments.